Good evening, and welcome to this presentation titled Business Case for Change, focused on socioeconomic disparities in San Juan County and the financial impact of care at San Juan Regional Medical Center. My name is Shelby Uselman, and I will be your presenter today. The healthcare network in Farmington, New Mexico has experienced significant changes, reshaping the community's needs and care landscape. After a rapid population decline, the economy shifted, resulting in poverty, unemployment, and a change in insurance payer sources. A sole provider community hospital, San Juan Regional Medical Center has weathered shifts in revenue and a decrease in state-generated support, states Chief Executive Officer Jason Rounds. Senate Bill 268 in New Mexico terminated the sole provider community program and bankrupted the county's uncompensated care fund, creating a deficit of $6 million. Concurrently, New Mexico adopted Medicaid expansion, increasing insurance coverage to millions of New Mexicans and residents in San Juan County. Government-funded insurance coverage became and persists as the primary source of reimbursement at a rate of 86%. While the rate of insurance coverage improved, the utilization of primary care did not, compounding the burden of chronic disease within the community. These changes have had a sustained impact on the financial capacity of SJRMC and the community. The Affordable Care Act Medicaid expansion dramatically improved the percentage of the population lacking health insurance from 21.1% in 2020 to 7% in 2023. Despite this, the burden of uncompensated indigent care at San Juan County is substantial, totaling $32,441,000 in 2023. Along with 7% of residents without health insurance, this sum is attributed to the prevalence of chronic disease, access barriers to primary care, and preventable hospitalization in San Juan County. According to recent data, only 62.3% of residents have a source of ongoing primary care, representing an opportunity to decrease this gap in healthcare utilization. The foundation for pursuing this gap is to decrease the financial impact of uncompensated care for preventable hospitalization by improving the percentage of patients who receive chronic disease management through an ongoing source of primary care. In addition, this change initiative has the potential to improve the rate of death in San Juan County associated with chronic diseases such as diabetes, alcohol misuse, and cirrhosis. In 2023, diabetes-related deaths in San Juan County were twice the national average. Alcohol-induced deaths were 7 times the national rate, and deaths from liver disease and cirrhosis were 5 times the Healthy People 2030 goal. The focus for evidence-based change solutions was obtained by examining the unique community needs identified by the Community Health Needs Assessment. Barriers to ongoing care access were broken down to identify specific causes. As the two most prevalent factors, obtaining an appointment, 26.8%, and finding a doctor, 17.5%, were selected as primary improvement areas. Considering these unique needs, Michigan's alternate Medicaid expansion plan is proposed as a statewide policy change to improve engagement in primary care, decrease preventable hospitalization, and improve death rates associated with chronic disease. Through a Section 1115 waiver from CMS, Michigan implemented the Healthy Michigan Plan, or HMP, available for beneficiaries within 133% of the federal poverty level. The HMP emphasizes preventative primary care by designating a primary care provider upon enrollment and encouraging beneficiaries to schedule an appointment within 60 to 90 days. At the initial PCP visit, patients complete a health risk assessment, examining health behaviors and providing the PCP with specific areas for improvement. After the HRA is submitted to their health plan, patients are eligible for incentives such as discounted premiums, reduced copayments, and gift cards. In addition, copayments for preventative visits or follow-up for chronic disease management are waived. This not only incentivizes healthy behaviors, but helps to eliminate barriers associated with out-of-pocket costs. Organization-level initiatives to mitigate risk and promote primary care will also be examined. Engagement in primary care has been linked to improved outcomes, increased healthcare access, decreased hospitalization rates, and fewer emergency department or ED visits. It has also been strongly correlated with improvements in healthcare spending nationally. Medicaid expansion across the nation is associated with a 12.1 improvement in PCP access, as well as improvements in the early diagnosis of chronic disease. The benefits observed as a result of the HMP can be used as a predictor of success. After implementation, the rate of beneficiaries with an ongoing source of care increased from 73.8% to 92.2%, 89.5% of which documented a claim for a PCP visit. Of those with a PCP claim, 91% reported an opportunity to discuss health promotion and disease prevention with their PCP. Measurable outcome benefits were evidenced by an 87.9% reduction in healthcare-related financial stress, prescription medication access, support for healthy behaviors, and improved physical health. Preventable ED admissions have been associated with impaired access to primary care and social determinants such as a lack of education and poverty. After HMP implementation, utilization of the ED as a primary source of ongoing care decreased from 16.2% to 1.7%. As a rural medical facility that receives 86% of its reimbursement through Medicaid and Medicare, SJRMC qualifies as a disproportionate share hospital, or DSH, receiving additional payments for uncompensated care from the federal government. Based on SJRMC's public record, SB 71 for 2023, the total cost of indigent care was over $126 million. After the qualifying DSH payment was applied, state supplemental program payments in the form of hospital access, targeted access, and safety net care pool distributions were applied. Lastly, the previously bankrupt county health plan contributed a small sum to SJRMC's uncompensated care debt, totaling $32,441,000 for 2023 after all payments. Disparities in access to ongoing care are associated with avoidable emergency department utilization and recurrent hospitalization. The Centers for Disease Control and Prevention posit that patients who face disparities such as low health literacy and poverty are less likely to initiate healthy behavioral changes or engage in preventative care. They are also less likely to engage in self-management of disease, have a higher likelihood of utilizing EDs for care, and suffer elevated mortality rates. In examining uncompensated care costs by cost center, care received in the emergency department was the highest charge, representing 15% of the total sum of uncompensated care. This data revealed a significant opportunity in which to mitigate potential risks to the organization's financial security while promoting ongoing patient care. In addition to the proposed policy change, the implementation of a patient navigation program is proposed as a strategy to mitigate the financial risks associated with preventable ED utilization and uncompensated care. Patient navigators are individuals with healthcare and social services knowledge who are embedded in the ED to facilitate follow-up care, identify social resources, and improve care access. Low and moderate acuity patients are approached by the patient navigator during the discharge phase and provide patients with resource materials tailored to each patient's unique social needs. These individuals also facilitate outpatient follow-up by initiating a post-discharge phone call to the patient within 72 hours. Part of the role of the patient navigator is to perform a social risk assessment on low to moderate acuity ED patients to identify socioeconomic or access barriers that impede effective care. Frontline clinical screening for socioeconomic barriers is an evidence-based approach to identifying disparities that prevent primary health care. Paired with referral and resource support, it has improved patient access and awareness of local support systems. The assessment addresses disparities such as transportation barriers, housing needs, home environments, food insecurity, and a lack of support systems. Indication of disparity in any field triggers a conversation during the patient's visit about community resources that may be helpful to them. Patients are not formally enrolled in services but are empowered through supportive conversation and resource options. Conversations guided by clinicians are conducted in a way that avoids blame and stigmatization. Honest and open consultations about poverty, access barriers, and social needs help guide organizations in identifying appropriate education, resources, and support systems to mitigate financial risks and disparities that prevent engagement in primary care. Despite coverage expansion, Medicaid patients experience additional barriers in accessing primary care compared to patients with employer-provided insurance. Part of the role of the patient navigator is to facilitate access to PCPs by assisting patients in scheduling a follow-up appointment upon discharge. In a recent study reviewed by Cummings et al., Engagement with primary care was facilitated by screening patients for PCP access, identifying available PCPs, and scheduling a follow-up appointment for patients. Upon admission, patients were screened by registration and PCP information was validated or added to the electronic health record. PCPs within the state or local region were entered into a registry that populated contact information. Patients who obtained regular care for chronic conditions from specialists such as nephrologists may have specialists listed in the PCP field. Patient navigators then utilize this information to schedule a follow-up appointment for the patient with the PCP within 14 days of discharge. For patients without a PCP, the navigator offered to schedule the patient an appointment within the institution's primary care clinic. SJRMC is well suited to initiate such a plan, having established several partnerships with local primary care and pediatric offices according to rounds. The volume capability of these entities should be considered for limitations, establishing additional partnerships to expand capacity. Increased rates of preventable ED admission have been associated with a lack of access to primary care and social determinants such as poverty and a lack of education. Nationally, approximately 30% of ED visits are projected to be non-urgent and could be treated in PCP settings. Applying this statistic to SJRMC volumes for 2023, it is estimated that 16,264 visits may have been avoidable. The implementation of patient navigation programs with social risk assessment and PCP referral has been associated with cost savings ranging from $331 to $1,369 per patient within 12 months of implementation. Applying the average cost savings of $850 per patient to this scenario, it is feasible that SJRMC could reduce unnecessary or uncompensated costs by $13,824,570. Considering that the average salary of a patient navigator is $58,231 per year, it is feasible for the hospital to hire 6 and still improve liabilities by $13,500,000 annually. Prior to the implementation of the Patient Protection and Affordable Care Act, factors impeding primary care access included race, ethnicity, income, gender, unemployment, and a lack of insurance. Compared to white patients, Latinos and African Americans were less likely to have a PCP. The fundamental purpose of the Medicaid expansion was to promote health equity among marginalized individuals such as those living in poverty and minority groups. New Mexico's decision to expand Medicaid is symbolic of equitable progress, yet Medicaid patients still encounter more barriers to obtaining primary care than patients with private insurance. Patients who are new to the concept of primary care coverage need time and support to familiarize themselves with new processes and develop trusting relationships with providers. To facilitate access, support systems such as translation services, transportation, and telehealth should be utilized to promote cultural sensitivity and equitable treatment. The proposed changes and mitigation strategies ensure that cost and access are equitable by treating the whole person, prioritizing and addressing socioeconomic barriers that prevent equitable care. Safety net providers such as SJRMC are committed to providing care to vulnerable community members who lack insurance, experience poverty, or are dependent on public programs. Through the implementation of effective federal, state, and organizational policies and support programs, high-quality health care can be accessible to all. At this time, I'm happy to answer any questions that you may have about this proposal. Thank you so much for your time and attention today.